Medurstand. Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and in the series of lectures on different liver disorders, today we're going to talk about hepatocellular carcinoma. And you may be wondering why I'm talking about a condition which is mostly dealt with by hepatologists and the surgeons and medical oncologists. The reason I'm going to talk about this condition is that this hepatocellular carcinoma often develops in the background of a liver disorder which is taken care by many physicians. So physicians need to know the basics of this disease, how to make a diagnosis and how to handle the case, at least initially, and then of course case may be referred to a surgeon and oncologist. So as a disclaimer, I would say that this lecture is provides you the basics of this topic, and if you want to know more, of course you can refer to the literature. And of course, if you are a hepatologist or if you are a surgeon or medical oncologist, you would find this as a very brief, but others will find it quite adequate. So what is the definition? It is a tumor, we all know it is almost always a malignant tumor, and tumor arising from hepatocytes. Liver has got many types of cells, but the tumor arising from the hepatocytes is called hepatocellular carcinoma, and it often develops in the background of chronic hepatitis C or hepatitis B infection. They may or may not have cirrhosis. Particularly in hepatitis B infection, patient may be having a chronic infection which is labeled as just patient is carrier or patient is healthy carrier, and these terms we do not use anymore, but previously somebody who has this hepatitis B virus but not showing active replication, not showing any injury, and not ALT is normal, so they are often said that they have chronic hepatitis B infection, not hepatitis. So it could develop in that context also. In hepatitis C, typically we have background of chronic liver disease, and then patient develops a tumor, a hepatocellular carcinoma. But in hepatitis B, there could be a normal background of liver, and patient may develop hepatocellular carcinoma. Other conditions are alcohol intake, that usually when it causes fibrosis, cirrhosis, that leads to carcinoma, and non-alcoholic steatohepatitis. This is coming up as a very common condition, and many people are getting fatty liver and then progressing to NASH and fibrosis and hepatocellular carcinoma. Exposure to certain toxins like aflatoxin can also cause hepatocellular carcinoma. Hepatocellular carcinoma is very common. I would say the word very common, if not, I mean it's common in our part of the world because of prevalent hepatitis B and C. It is one of the commonest tumors in our country. Because of mutations, these conditions, they promote cellular growth, and when there is cellular growth, there could be a random mutation, and that may lead to formation of a tumor which may be unifocal, or many times it may be multifocal. And sometimes you know that there is a tumor but you are unable to clearly identify the tumor because it is infiltrating type and the clear outline may not be identified. Screening tests, and who would need screening? Those patients who have chronic hepatitis B infection, even if they are treated, they are cured, their PCR is negative, they would require some kind of screening. And those patients who are hepatitis B surface antigen positive, whether they have chronic hepatitis B infection where ALT is normal, or chronic hepatitis B hepatitis where ALT is normal, whether or not they are being treated or whether or not they have responded. So all these patients with hepatitis C or hepatitis B should have some kind of screening. I suggest once a year would be good enough, because we have to conserve resources and at the same time we want to make the diagnosis as early as possible. So once a year screening for patients who have this predisposing factor should be done. I think patients who take alcohol regularly, those who have fatty liver, NASH, they should also have this screening test. There are two screening tests. One is ultrasonography, and you all know this is an imaging technique and very simple bedside test and without any radiation, available everywhere, and with a request that you are looking for a possible hepatocellular carcinoma. Then I think that sonologist will concentrate on liver more, and if there is any lesion, that will be picked up. In this case, it's a fairly well circumscribed and very different. This is a normal liver tissue and this is hypodense. You can see, and this is little blackish, and this is the characteristic very clearly outlined with capsule. So hepatocellular carcinoma, if diagnosed on early ultrasound, I think the prognosis will definitely be better, because all those treatments which are possible, they work better when we offer them early. And then we have alpha fetoprotein. This is the blood test, and this would detect only the secretor hepatocellular carcinomas. I think about 70%, 70 to 80% of hepatocellular carcinomas, they secrete this fetoprotein. This protein is normally present in fetus, but it may become positive in some malignancies, and the most important malignancy is hepatocellular carcinoma. And these are the values during screening. If the level is below 40, you may feel assured that this is normal. And if it is more than 400, it is almost surely hepatocellular carcinoma, and patient should definitely undergo further testing. And 40 to 400 may be borderline, and this has to be kept under close observation. And if this patient happen to have any ultrasonographic abnormality which is consistent with hepatocellular carcinoma, these patients should also be considered confirmed cases. Now, why both are needed? Because none of them is 100% sensitive or specific. So I think in almost all patients, both should be done, because I'll show you in the next slide, there are a number of abnormalities which can mimic this hepatocellular carcinoma on ultrasound. And there are a number of conditions other than hepatocellular carcinoma, chronic liver disease, and some other malignancy where alpha fetoprotein may be elevated. And as I told you, some tumors, they are hepatocellular carcinoma, but they do not produce this alpha fetoprotein. These are the conditions which should be considered if there is no chronic hepatitis B or chronic hepatitis C or some other strong risk factors, and especially if the alpha fetoproteins are normal. Now, on ultrasound, there are conditions where there could be a nodule, dysplastic nodules in people with cirrhosis, adenoma, and fibrous nodular hyperplasia, metastatic disease. I mean metastatic tumor. We of course will be equally concerned if somebody has a malignant deposit in the liver coming from elsewhere, but from diagnosis point of view, it would not be hepatocellular carcinoma, from colon or from other tissues. And then primary hepatic lymphoma, this is also a possibility. So if somebody has chronic hepatitis B and hepatitis C infection, alpha fetoproteins are elevated, then I believe any nodule on ultrasound can be interpreted as hepatocellular carcinoma, but otherwise you need to consider all these conditions. And of course, you might have to refer the case for further testing, a biopsy or maybe other tests. Now, in malignancy, typically the diagnostic test is biopsy, and this used to be true in hepatocellular carcinoma also, and it perhaps still applicable. But because of the limitation of biopsy, because of the fact that biopsy is an invasive test, very recently we have found that we can make almost as confident diagnosis of hepatocellular carcinoma on this multiphasic CT. This is because of its unique properties. Now let me first explain those properties of this hepatocellular carcinoma before we can read this CT. You know, our normal liver has got dual supply. 20% comes from the arteries, hepatic artery, which is a branch of celiac artery. Now this artery supplies blood to the liver and provides nutrition and provides oxygen like any other organ does. But 80% of the circulation to the liver comes from the portal system. These tumors are arterially fed. This is the fact that you need to know before you can understand this triphasic or multiphasic CT finding. A tumor in the liver is predominantly, if not exclusively, fed by hepatic artery or one of its branches. So that is the phenomenon which we use. So when when contrast is injected, contrast passes through different phases, arterial phase and portal phase, and then late venous phase. So in the initial phase, the computer takes images. In the initial phase, when the contrast is still in the arteries, like in aorta, hepatic artery, and arteries, branches of hepatic artery, then this tumor would have lot of contrast in it and will be enhanced. So you can see this is more denser than background liver tissue. So this is aorta, and this is also showing contrast. So you can see that there is a growth, there is a well circumscribed rounded opacity in the middle of the liver, in the center of the liver, which is enhanced during arterial phase of contrast. And these two are also perhaps small tumors, but I'm going to concentrate on this one. And in the late phase, washout portal phase, when arterial phase is over, now the contrast has gone to the venous side and have passed through the capillaries, has gone into the venous side. Then you see that this tumor is not enhanced at all. You see, this tumor is like it has got the same pattern as a neighboring liver. So this is because the contrast has been washed out, and this would happen only if this part is supplied by hepatic artery. And in the third phase, the capsule is seen. The late phase, you can see a clear-cut capsule. So of course you can learn more on radiology lectures, or and a radiologist will tell you more, but this is the simplistic view of different phases of contrast. So this pattern of enhancement in the arterial phase and then washout in the portal phase and later formation of capsule in the further later phase is so characteristic of hepatocellular carcinoma that in the proper context, if somebody has chronic hepatitis B, C infection, and especially if the alpha fetoprotein is elevated, this pattern of CT is considered so specific, so diagnostic, that biopsy is usually considered unnecessary. We normally do not give chemotherapy or radiotherapy, or we do not perform extensive surgeries unless a diagnosis of malignancy is confirmed. But in this case, this imaging test is so diagnostic that the diagnosis is considered final and patient undergoes the treatment. So biopsy is mostly replaced by this triphasic or multiphasic CT scan. But those patients where alpha fetoprotein is not elevated, and those patients where you do not get this characteristic CT finding, perhaps biopsy will still be needed. Now, MRI is another imaging technique. In most conditions, MRI is considered better because MRI gives you better resolution, and plus MRI is without radiation, but MRI is more expensive and MRI is not available that readily also. But if available, I think MRI may give you the equally confident and sure diagnosis without the hazard of radiation. In this scan, you can see this is exit scan T2 imaging. You see this nodular heterogeneously hyperintense tumor, this one, and in later phase you can see that this is hypointense. This is T2 weighted, this is T1 weighted images, and there are different patterns. So you can see actually very well defined tumor. CT scan versus MRI, both are good. As I said, some patient would still require biopsy, especially if the imaging is not very typical, and especially if the alpha fetoprotein is not elevated, or if the background risk factors are also not present. So I think they will all be atypical, unusual cases, and if you see something on ultrasound, then we need to do biopsy, and this would be done in selected cases. Biopsy is not investigation of choice, not because it is invasive and the patient also doesn't really prefer, but because patient is likely to have coagulopathy. Any biopsy procedure may have this risk of bleeding, and if somebody has chronic liver disease, has got coagulopathy, the risk of bleeding, and there is a thrombocytopenia in chronic liver disease also. So in the background of chronic liver disease, taking a biopsy of the tumor may be particularly risky. Of course, it is done under specialized center, under special care, but only when ultrasound and CT scan and alpha fetoprotein, they do not provide a definitive diagnosis. Now, treatment, I'm going to start with this medicine. Of course, this is not a curative treatment, and there are no chances of achieving remission. Sorafenib is actually a tyrosine kinase inhibitor. Tyrosine kinase is actually a growth factor which promotes hepatocellular growth. So by blocking this enzyme, we only slow down the growth. We don't kill hepatocytes. We don't expect the liver cancer to go away or to melt away or to go into remission. It only can hold its growth for some time. So typically given to those patients who are awaiting a definitive treatment, and they might need resection or they might need liver transplant, but just to take time on your side, you start this medicines. It is 200 milligram, 2 tablets twice a day for as long as patient gets a transplant or resection. Long-term treatment with sorafenib is not likely to prolong life significantly. It only prolongs for a couple of weeks. That means it provided you a broader window for a definitive treatment to be offered. There are many other kinase inhibitors and many other monoclonal antibodies, and sometime when the tumor is advanced, then it is treated with chemotherapy. That is the subject which is beyond my scope, so I will not be talking about that. Those who are interested, they can read the literature. And this is one of the treatments called transarterial chemoembolization TACE. So transarterial, you can well imagine, if you read the word transarterial, you go through the artery. In this case, the femoral artery. Catheter is passed through the femoral artery up into the aorta, then celiac artery, then hepatic artery, and then we reach, of course, the interventional radiologist gets very close to the tumor, and this is done under ultrasound control, under fluoroscopy and other techniques. So a catheter is passed. The aim is actually to deliver a medicine which is a chemotherapeutic agent. Why do we have to take this route? Why can't we give it intravenously? Because intravenously administered chemotherapy is likely to have lot of side effects. The entire body will be exposed to the chemotherapy, and patient will end up having many complications, and you will probably not be able to give as high dose as you would otherwise want to deliver into the lesion. So this way, once the interventional radiologist finds the feeding artery, he injects this otherwise known chemotherapeutic agent like doxorubicin or cisplatinum, and this of course is again beyond my scope. So those substances are injected, and then another substance, a jelly like substance, is injected which will occlude the artery. What is the advantage of occluding hepatic artery? There are two advantages. Number one, it will let this chemotherapeutic agent to remain in the tumor. It will not be washed out. Number two, it will also lead to ischemic damage, necrosis to the tumor. So I think these two can kill the liver cells, the cancer cells, and you can expect that it will shrink and patient will have some prolongation of life. Now, you just by the fact that this is actually not exactly removing the tumor, you cannot expect complete remission. There are patients who have very good response and they have significant prolongation of their life with successful TACE, but by the inherent nature of the treatment, it cannot cure you. So it is one of the techniques, but of course those patients who cannot undergo resection or liver transplant, for them this is one of the treatment options. TACE. In our country, there are limited places where TACE is done. You need to have a very specialized center and a highly trained intervention radiologist who can do this. Then there is another treatment very similar to this one, that is called brachytherapy. Now with this, they inject certain crystals which emit radiation. Certain radioactive substances are converted into crystals and they are injected into the tumor and they continue to emit radiation. So it is like long-term in situ radiotherapy. So this is done in many cancers, like in prostate cancer, but this is one of the cancers where brachytherapy can be applied. This is another technique, radio frequency ablation. A catheter is passed into the tumor. I think it is passed transcutaneously under ultrasound control and under CT control. The probe tip goes into the tumor, and usually there are multiple prongs, and then a radio frequency waves are transmitted and they have that damaging effect. So this tumor-like thing will be converted into a necrotic material. So this is another palliative procedure. You can again imagine it is very hard to see that the tumor will be completely removed and the normal liver will not be affected at all. So because we always try to spare normal liver, so inevitably some malignant tumor will remain behind and perhaps complete ablation will not be possible. But this, like TACE, will provide some additional years to the patient's life, and later on maybe patient can get a liver transplant or resection. So all these techniques, the medical treatment, the TACE and this radiofrequency ablation, they are all offered one after the other, and hepatologists or oncologists will find which therapy is best for which patient. Resection is removal of that affected tumor. There is of two types. One is non-anatomic, that is called wedge resection. That means just the tumor, and I think without any anatomical reference, that affected part is removed. This is called wedge resection. The background is liver is actually divided into multiple segments. I think there are 8 ones based on the blood supply. So if you a specific part, an anatomical part based on blood supply, 1, 2, 3, 4 segments are removed, it is called segmental or anatomic, otherwise a wedge resection. Now, there are issues with this technique. Number one, it's a major surgery. Patient is already likely to have background liver disease, so patient might not tolerate this surgery. Number two, you need to have a relatively localized disease to have this resection. Most patients are diagnosed late, very unfortunately, when they have metastasized in the liver or outside the liver or in the entire body, or background liver is so bad that we know that after resection of the tumor, the background liver will not be able to take up the total load, so that become the contraindication. But some patients, they would need this one. Ultimate is liver transplant. Very unfortunately, many patients are diagnosed very late, and there are many other issues with liver transplant. And I'm going to just mention a few of them. Many patients do not qualify for one or the other reason. The disease is very advanced, metastasized, background liver disease is too advanced, or there is another comorbidity, or scarcity of donors. Although even if the donor is a cadaver, the donors are limited. In our country, it is usually a living person who is a donor, and we need to have a donor who is not only willing to donate but is otherwise also fit. So donor will be screened for with many tests, and it is possible that patient for on technical reason is ruled out as a donor. So scarcity of donor is another limiting factor. Facilities of operation are not available many places, very limited places, and it's very expensive in our country because people pay from their pocket. So this treatment is very expensive for most of our people, and there's high mortality. High mortality because the big long surgery on somebody who is otherwise also very sick. And theoretically, I hope that never happens, but theoretically the mortality could go to 200%. Now you may be surprised how come mortality go beyond 100%. 100% would mean that everybody who is operated dies. That is, of course, this is something we don't want. But 200% means if the donor also dies, because donor also undergoes a big surgery, and in a very unfortunate situation, it is possible that the recipient as well as donor both die. So that is why liver transplant is done only in a very specialized center by very highly trained people, and only those patients who otherwise qualify for liver transplant. So due to this, many patients who have hepatocellular carcinoma, they do not benefit from this treatment option. Contraindication for liver transplant, there could be many actually, but these are the ones I have identified. A metastasized liver cancer, some liver cancer which is already gone beyond liver. Of course, it could go anywhere. It could go to the bones, it could go to the lungs, it could go to the brain, it could go to any other organ. So if it has gone beyond liver, that means even if you put a new transplant, disease which is gone elsewhere is going to limit patient's life. So that would be a contraindication for operation. Portal vein invasion. Not only it will make the surgery difficult because portal vein is thrombosed or portal vein is metastasized, but because if the tumor has gone into portal vein or hepatic vein, it means it has already gone beyond liver. So that would be a contraindication. And patient unfit due to comorbidities. It is a major surgery, long surgery, if somebody has underlying lung disease, underlying heart disease, very old, so these patients would not be considered appropriate cases for liver transplant. So these are some of the contraindications, and there are actually more. Now, prevention, since I have portrayed a very bleak picture, so there should be some ray of hope, and that is in prevention. You know, it is actually possible in our country if we work on these conditions early, and as a society we can definitely reduce the burden of hepatocellular carcinoma. Mass vaccination with hepatitis B vaccine, which is now available, it is now actually recommended that every newborn should get this vaccination, and those who were not previously vaccinated should be vaccinated, particularly those who are at greater risk: healthcare workers, doctors, nurses, paramedics, and other people who are more at risk. They should get vaccination. Identification and treatment of chronic hepatitis C. Hepatitis C has become a curable disease. If there is a person who has this chronic hepatitis C, should be treated, and by that hopefully we can reduce the prevalence of hepatocellular carcinoma. Alcohol abstinence, because that is also a risk factor, and prevention of NASH, non-alcoholic steatohepatitis. I told you in my other lecture that this is a relatively common condition. Even in our society, many people have fatty liver, and some of them they develop NASH and fibrosis, and some unfortunately will develop hepatocellular carcinoma. So that should be prevented by appropriate measures. With these, we can hopefully prevent a very high prevalence of hepatocellular carcinoma in our country. Not actually very high, but fairly high. The prognosis, once diagnosed, the prognosis is not good at all. I think even at the very diagnosis, the prognosis is poor. It's very hard thing to explain to the family. I think I always make a separate sitting with the patient and to explain to them and the patient or the family, because you need to explain that there isn't much that we can do. I think in many cases all we can do is end of life care and the support treatment and prevention or the treatment of pain, and reassurance that whatever is possible we are doing. I think that kind of approach, and the family must be explained if surgical treatment is not possible, because they should not feel guilty that they are unable to do something. I think we need to counsel the patient. The prognosis is not very good. Some fortunate people who have limited disease, early disease with good background liver, and who can afford this expensive surgery, they may have a relatively good prognosis, but the disease remain bad. Thank you very much. This was, as I said, a brief account of hepatocellular carcinoma from an internist for trainee internists, and this focuses on the basics, and of course details can be found elsewhere. This is a tumor which develops in the background of a medical condition, and the initial treatment is also medical. Investigations are also done by internists, so that is why I thought it would be appropriate to cover this condition in my lecture. This was Aziz-ur-Rehman from Medurstand. I really look forward to see you in my next video, which should be, I think now should move on with another organ. Thank you very much.